lung cancer screening. Any of you who have been part of the learning community or heard other webinars that we've done, some of this information will seem similar. So let me go on to the first slide, please. Thank you. So I wanted to start with a definition, and I highlighted in red what I think is a very important point to take away from this slide. So shared decision-making is a process. It's not just handing somebody a decision aid and expecting them to go off and figure out whether they want to be screened or not, for instance. So it's a process that includes the patient, perhaps others, family or friends who they want to help them with the decision, and one or more clinicians that engages the patient as part of the decision-making by providing them with accurate, and I thought the word unbiased was in there, but it has to, even if it's not in there, the information has to be accurate and unbiased about the options, the pros and cons of the options and the outcomes, and then tailors the decision, and then whatever follows the decision, to what's important to the patient, which we often refer to as preferences and values. Next slide, please. So decision aids are tools that provide information to help people do shared decision making. The information is about the decision to be made, the pros and cons, and often they will also help a person think through what might be important to them in relation to the decision they're making. Again, highlighted in red, they are part of the process of counseling by a healthcare practitioner. They don't take the place. That doesn't mean there are not people out there who you all take care of, who, if you gave them a good decision aid, could understand the information and come to a decision with minimal, if any, help. There are those folks out there. Many, if not most, of the people we take care of, the decision aid is only part of helping them make the decision. Next slide, please. We know from a series of systematic reviews of the literature done by the Cochrane collaboration. This is an international volunteer effort that uses high quality approaches to doing systematic reviews of the literature. So we know for sure that using a decision aid leads to better quality decisions. Those first 5 bullets about knowledge, accurate risk perceptions, etc., are all broadly considered decision quality measures, that when you use a decision aid, people make better decisions and people are more comfortable with the decisions they make. The 6th bullet is the most controversial piece of shared decision making, because there are some who believe that shared decision making is also a way to save money in healthcare, that if people are well informed, they will often not choose to have the kinds of elective procedures, some of which might be expensive, that we might recommend to them. The literature is now solid enough that that was part of the conclusions of the last review. I think 2014 was the last. They may have even reviewed the literature once more since then with similar conclusions. I would say that because there's still controversy, the question of do people really do less procedures takes longer term follow-up than any of the studies I'm familiar with. I'm more comfortable leaning on shared decision-making with decision aids leads to better decision-making process. I think we still don't have enough evidence about whether it affects people's decisions and the cost of care in the long run. Next slide, please. And as I said, shared decision-making is a process, in other words, a set of steps. And this is what is required as part of the lung cancer screening process. So I want to just quickly review the steps are, first of all, to let the person know that there is a choice in front of them and that you want them to be involved, and that you're going to help them to understand the information and participate in the decision. You then provide information that could be by sharing a decision aid with the person, and it reviews the pros and cons, the benefits and risks of the various options, one of which is always to not do the thing. So one option for anybody who's facing, who's at high risk for lung cancer and meets the eligibility criteria is you can choose to be screened, you can also choose not to be screened. As I said, for many of our patients, this step, giving the information, helping them process the information, needs some help. And one of the challenges in the work we've done on shared decision-making in the past is practices don't necessarily have somebody who can help a patient review the information and answer questions. And I'll talk a little bit more about that later in the presentation. So once you've explored preferences and you understand for this person, either they want to proceed with having screening or not, then the last step in the process is to make sure that the decision that's made is implemented, essentially. This is much more of a problem with things like advanced care directives, where you may have a long conversation with somebody about what they want or don't want at the end of their life, but if that information is not available, they may not get the care that they wanted. So making sure the loop is closed, people know what the patient preferences are, and then you implement the decision based on that. That's the last step, and it's very important. Next slide, please. So now let me quickly go over the lung cancer screening part. So Medicare is beginning to require shared decision-making for certain kinds of procedures and surgeries. There's only a few now. The expectation is this is the beginning and something that will continue. So for this test, Medicare decided that reasonable people looking at the pros and cons might choose to be screened, but might choose not to be screened. So they have required this as part of a counseling visit that you'll see includes other things. The decision aid tools come in a variety of formats. They can be on video, they can be print. There's a number of them on the web. I'll share those websites at the end. Just to give you a preview, the Maine Lung Cancer Coalition is starting a process. Some of the people on this call are going to help us with it. We want to take a look now, as we're in the last year of our grant, what are all the decision aids out there? And we're going to develop a process using our colleagues from around the state to make recommendations on what we think are the best ones out there that will be then available for all of you to use. We are going to lean there. Many shared decision-making tools are now becoming proprietary. In other words, you have to buy them. That is an unfortunate direction, and our focus is going to be on those things that you do not have to pay for, that are available publicly to anybody who wants to use them. So more to come by late spring, early summer, I would expect. We'll share that with you. Next slide, please. So just to briefly remind you of the required elements of this counseling and shared decision-making visit. So you want to confirm eligibility. We've talked about eligibility criteria already. I won't review that again. They require the use of a decision aid. So I think giving you a sense of what the best ones out there are will be useful. The decision aid has to consider the benefits and harms of screening, remind people what happens if you have an abnormal in terms of follow-up testing, talk about the false positive false negative rates, talk about the radiation exposure that comes with low-dose CT scans. Next slide, please. Reminding people that this is not a one-time event, but that it's recommended annually. And reviewing that as someone gets older and potentially develops more comorbidities, there might be a point when they're sick enough that continuing to screen may not make sense. And then counseling about tobacco treatment is the final part of the required visit. Next slide, please. I'm sure you all know these, but just to briefly remind you that the benefits are that lung cancer screening finds lung cancer earlier, and that gives a better prognosis. The numbers from the study are 3 fewer people dying of lung cancer per 1,000 screened, which is a 20% relative risk reduction. And unlike any other cancer screening test currently available, lung cancer screening has been shown to reduce death from all causes. This is important for reasons that I could get geeky about, but I won't unless somebody asks me a question. But this shows people who were screened compared to non-screened, 5 fewer deaths per 1,000, overall a 6.7% reduction in the risk of dying from any cause. And because the low-dose CT scan can find other things, sometimes other important things are found that benefit from treatment. That's probably why all-cause mortality is reduced by lung cancer screening. Next slide, please. Then the harms, one is that not every lung cancer shows up on screening, so there are some false negatives. False positive rate is probably the biggest harm or risk. We used to talk about numbers closer to 250 or even 300 per 1,000. As we've gotten more experience with lung cancer screening and as the College of Radiology has adjusted the lung-RADS criteria, there's actually less false positives now, so that's good. But a false positive means at least worry, sometimes needing other studies that can be invasive and therefore potentially risky. Small numbers, but certainly things people need to know about. Overdiagnosis is the most complicated issue to try to figure out, which is that we might be finding cancers that if never found would not grow and would not ever cause problems. This is a known issue in prostate cancer screening. The extent of this problem in lung cancer screening, I think we don't know yet. And then radiation exposure, as mentioned, one low-dose CT scan is equal to about 6 months of what all of us get walking around, living our lives day to day. Next slide, please. And this is an example. This is the Agency for Healthcare Research and Quality decision aid. This is, as I've started to tell people, 1 of 4 pages. So this thing is a little long, I think, for most patients. And the icon display, which shows all those numbers I just gave you in graphic form, there's some controversy as to how much patients are really able to understand this, but I just wanted to give you an example of what a decision aid looks like. Next slide, please. So just the last 2 slides, I'll go quickly. These are websites. The first one is a set of websites that have information about the shared decision-making process. The third one down, the International Patient Decision Aid Standard Ratings, or IPDAS. That's an A to Z list of many decision aids that are available around the world. And if you're looking what's out there for a particular topic that I'm interested in, that's the place to go. The next slide, please, shows the array of decision aids that we believe are still in the public domain, available for free. They're going to be part of what we review and make recommendations on. We're also looking for others. In fact, if any of you are using a decision aid that's not on that list that is on the screen right now, if you would send me an email, it's really easy, korsen@mmc.org, either with a copy of what you're using or just a description. We're trying to catalog that right now. So that's all I've got. I know we were down to the last minute. I think I'm in under the gun, and I don't know if we have